everybody. Welcome back to Queerantine. It's been a while since we've all seen each other. I'm Amy. I use she, her, hers pronouns, and I am the program coordinator of the LGBTQ Center for Seneca and Ontario counties.
And I'm Mitch. I use he, him, his pronouns. I am Amy's co-coordinator, and I primarily serve Wayne and Yates counties.
Yeah, and today we have a really special guest with us. We're really excited to have this discussion. We've been in the works getting it together for the last couple of months now, so we're really excited today to have Hannah Farley here. She is with Thompson Health, and she's going to talk a little bit about some important information. So Hannah, if you'd like to introduce yourself, we would love to know a little bit about you.
Yeah, thanks. I'm Hannah Farley. I use she and hers pronouns, and I am an outreach coordinator with the Cancer Services Program of the Finger Lakes region. It's a New York State funded program that pays for breast, colon, and cervical cancer screenings and diagnostic care for folks that don't have health insurance and meet certain eligibility requirements. So that's what I do.
Awesome. How long have you been doing this?
About 2.5 years. I'm just kind of rural outreach person. So I work in Wayne, Ontario, Yates, and Seneca counties, trying to kind of go around, educate folks about what cancer screenings do they need based on their risk, on their age, and then, really the importance of those cancer screenings. And also I can help to get those screenings on their calendar with them to help them get them paid for and find a provider if they don't already have one to get connected with.
Awesome. Well, we're so excited to do some learning. I know we've talked a little bit off the recording about how there are such discrepancies between healthcare for the LGBTQ community and for our cisgender or heterosexual community members. So I'm really excited to get the information and hear what you have to say.
Yeah. So let's see. Do we want to kind of maybe get right into it, or?
Sure. I will say, I'll give a warning, where Mitch and I are sitting right now, we have the entry door to our agency over on this side, and then we have train tracks on the other side. So if there's some background noise ahead of time, I apologize.
Okay, well, we'll keep going. We'll try to go over that. Okay, so, hi, I'm Hannah. And so today we're talking about certain cancers. We're really talking about breast, colon, and cervical cancers and the screenings. And we're also going to talk about some of the really unique barriers that LGBTQ plus individuals face when it comes to healthcare, particularly when it comes to their cancer screenings. And so just a little history about me before we get started. Kind of why I do this is back about five or 6 years ago, I got a phone call from my mom who she needed a ride to the emergency room, and she's never had a sick day in her life, and she needed a ride to the emergency room, and because she was feeling chest pain. And so I picked her up, I took her there, and she thought it was like a minor heart attack or something. So, hours later in the emergency room, they came back after doing multiple tests and they found a large mass. And that was really shocking because she'd always gone and gotten her cancer screening. She'd always was up to date with her health care. But it was a cancer that couldn't really be found with a regular screening. It was kidney cancer. But the fact that we have these cancer screenings that can find cancer early before it becomes a bigger issue, and also screenings that can actually prevent certain cancers like cervical cancer and colon cancer. I think those are so important. So that's really my passion behind this, and I just hope that for most people they don't ever need to get a phone call like that. So with that, before I talk about the different cancers, I do want to just mention COVID-19. Is like we have to talk about COVID-19 just for a second. So a lot of people did put off their cancer screenings during the height of the pandemic. And the recommendations actually at the time were to postpone non-essential healthcare visits. And that made perfect sense. But now it really, although we're still experiencing another surge of COVID, it is still important to get to your doctor's office, get these potentially life-saving cancer screenings. And so, because they can save lives, and they are done safely. So, quickly, did you know cancer is the second leading cause of death among New Yorkers? Heart disease is still the first, but cancer is a very, very close second. And cancer screenings can save lives. You're going to hear me say that a bunch of times. And the screening with a mammogram can actually help to find breast cancer early when treatment can be more effective. And then cervical cancer and colon cancer screenings can actually, they can prevent those cancers by getting screened regularly. So a really common question, and you've probably asked this yourself, is what causes cancer? And so what cancer is, it's a condition where abnormal cells just kind of grow out of control. And these abnormal cells form tissues that can eventually form masses known as tumors. And a lot of people ask, why did I get this? What happened? Well, there's over 100 different kinds of cancers, and there's just as many, if not more, possible causes for these cancers. And while we don't know really exactly what causes every cancer, we do know what can increase your risk for certain cancers, and we call these risk factors. So there are some things that can increase your risk for many cancers, although maybe not all cancers. And these include your age. So as we age, we know that our risk for many cancers does increase. Also, our race, depending on your race, you may have a higher or lower risk for getting certain cancers. And then, of course, your family history. So in your family history, that refers to something like a close relative, a parent, a sibling, or a child. And so, having a risk factor does not actually guarantee that you're going to get diagnosed with a certain cancer. And not having any risk factors doesn't mean that you can't get cancer either. So these are risk factors: age, race, family history. These are things that we cannot control. However, the good news is that if you live a healthier lifestyle, you can actually help to reduce your risk for many cancers. And so it's really important to check up with your doctor regularly, to eat more healthful foods, to exercise regularly, all these things that we know are good for us, to exercise regularly, and then to maintain a healthy body weight, and also to not smoke, because smoking doesn't just impact your risk for lung cancer, it impacts your risk for many, many other cancers. So, and those are things that we can control. So regular screenings can save lives, again. and a screening means checking for cancer before you start to experience any symptoms. And so today we're really talking about breast cancer, cervical cancer, and colorectal cancer, also called colon cancer. But before we really get into that, we're going to talk a little bit about LGBTQ+ and health. And so 11 million people report to be LGBTQ+ in the United States. Now there's over 300 million people in the United States. So 11 million is a good number. And studies have found that LGBTQ+ people do experience certain health and access to care challenges at a higher rate than their non-LGBTQ+ peers. And recognizing this, the National Institutes of Health, or the NIH, has identified sexual and gender minorities as a health disparity population. And they've identified them as a health disparity population to really encourage and support research in this area. But more specifically, we need more data on specifically transgender and non-binary health status individuals, on their health status, on their access to care, and on their preventative care. That is really an area that we're really lacking in. And because their needs are unique in this population, and they're likely different from individuals who identify as lesbian or as gay. So I'm going to share with you some data from a study that was just published, hot off the press, in July 2021. And this study refers to, they say LGBT plus and non-LGBT plus adults. So that's how we've labeled the information just when talking about the study. So LGBT plus health status, nearly 1 in 4 LGBT plus individuals report being in fair or poor health. Those are not positive things, versus the 14% non-LGBT plus individuals who report to being in fair or poor health. Also, almost half, 47% of LGBT plus individuals report that they have an ongoing health condition, versus only 40% of non-LGBT plus individuals. I think both those numbers are high. But obviously LGBT plus individuals who experience more ongoing health conditions. And then 21% of LGBT plus individuals report having a disability or a chronic disease, versus just 14% of their non-LGBT plus peers. So those are just some of the numbers. And then continuing to talk about their health status. So when we think about someone's health status, we have to think about, are they getting their regular screenings? Are they getting their checkups? Are they seeing the doctor? That matters when it comes to our health status. And we can see the blue there is for LGBT plus, and then the orange is the non-LGBT plus. So, and we see that fewer LGBT plus women ages 40 to 64, and I'll explain those ages in a little bit, report having had a mammogram in the past 2 years versus their non-LGBT plus counterparts. This is a 35% versus 64%. That is a huge difference. But in the better news, when it comes to cervical cancer screenings, the pap smear, and colorectal cancer screenings, the numbers are pretty similar between the non-LGBT plus and LGBT plus. So those are good, but obviously mammograms, those breast cancer screenings can certainly improve. And now when it comes to gynecological exam. So this blue here is for lesbian women, orange is bisexual, and then the green is non-LGBT plus. About 1 in 5 women, lesbian women, that 20%, and 12% of bisexual women say that they have never seen a doctor or a nurse for a gynecological exam, versus just the 6% of the non-LGBT plus women. So this pie chart just shows you how many women have reported never seeing a doctor or a nurse for their gynecological exams. And then, so we talked a little bit about health status. Now we're going to transition a little bit to access to care. So this survey asked people about their access to healthcare, and access to care is kind of a complicated subject to discuss, to measure, and to understand. But what was found, there was some good news from the study when it came to access to healthcare. They found that LGBTQ and LGBT plus individuals have similar rates of health insurance. They also have similar rates to a usual place of care. So they have like a usual office that they'll visit, or they're a hospital, emergency care, whatever it is, that's their usual place. Hopefully emergency care is not their usual place. And they also have a similar rate of having a regular health provider, a regular doctor, a family doctor that they see, that they're familiar with, and that doctor is familiar with them. In less good news, over 1/3 of LGBT plus individuals do report having at least one negative experience with a provider. And so, having health insurance and having a regular place place of care, having a regular doctor is a good thing, but that does not mean that people are always going to have a good experience with the care that they're receiving. And that can impact how much they trust that provider, how they feel with that provider. And so negative experiences included, there were reports that they said the healthcare providers did not believe that they were telling the truth. There's higher rates of that for the LGBT plus individuals versus non-LGBT plus, so not believing they're telling the truth, suggesting that they were personally to blame for a health problem, assuming something about them without asking. And then 29% of LGBT plus individuals reported that their provider dismissed their concerns versus 16% of non-LGBT plus individuals. And also a larger share of LGBT plus individuals report that they have had a household family member have problems paying certain medical bills in the past 12 months than the non-LGBT plus individuals. So 30% of LGBT plus report this versus just 19%. So that's for access to care. And then what are some barriers to care, right? So again, we discussed a little bit about the barriers to care, about, feeling comfortable in an office. So there's multiple barriers to care. There's barriers to care at the patient level, there's barriers to care at the provider level, and then also at the institutional level. But at the patient level, if you've had a previous adverse experience or if you've been discriminated at that healthcare office, then that's obviously a big barrier to returning to that office or feeling safe in that office. Fear of mistreatment is another concern, and that's a big barrier. Stigma can also feel just stigma against, how if you feel safe, if you feel respected in that office. And then of course, not having knowledge of cancer screening recommendations. If you're not going to the doctor's office regularly, you're probably not having a chance then to talk with the doctor about what screenings do you need. You might not know what's required for your health. And then also having a lack of insurance. So those are the patient levels to patient barriers to care. Now, at the provider level, the provider might not be trained in how to communicate with LGBT plus individuals. They might lack cultural competency. They might have a discriminatory attitude without realizing it, right? They might have implicit bias. And then also, it might not be a very welcoming office environment. And so that's at the provider level. And then at the institutional level, there's invisibility and an exclusion from clinical trials for LGBT plus individuals, right? We need more research. We need to understand the population's needs better. There's also a lack of standardized data collection, right? This is a study that just came out in July of 2021, right? And it's not, how we collect this data is not standardized yet. There's also a lack of insurance coverage for the appropriate screenings for transgender individuals. And then also a lack of screening guidelines that are specific for transgender individuals. So these are all things that need to be improved at the institutional level. And then there are some certain risk factors that LGBTQ plus individuals experience more than non-LGBTQ plus. And LGBTQ plus individuals tend to have higher rates of depression and anxiety than their heterosexual counterparts. And this can lead to increase in alcohol use, smoking, as well as obesity and unhealthy lifestyles, in which these tobacco use, alcohol use, and obesity are all risk factors for cancer. And nearly 1 in 4 gay, lesbian, and bisexual adults smoke versus only 1 in 6 heterosexual adults smoke cigarettes. So that's a big difference. And I like to talk about what this one Gwendolyn Quinn, she's a cancer researcher at Moffitt Cancer Center in Tampa, Florida. She says that these risk factors aren't caused by sexual orientation or gender identity. And she studies reproductive health for at-risk populations. She says that they found that LGBTQ plus individuals are just at a greater risk for cancers that are associated with these, including breast, cervical, colorectal, endometrial, and prostate cancers. So, and then also LGBTQ plus individuals are maybe less likely to get their regular health exams, including some cancer screenings, which if you're not getting your cancer screenings, that does increase your risk for those cancers. So with that, that's just it's kind of a little bit of a data dump on you all, but it's good information to know. With that, I'm actually going to then talk specifically about breast, cervical, and colon cancer and their cancer screenings, so that you can figure out exactly what screenings you need. So breast cancer. 1 in 8 women will develop breast cancer within their lives. So it's a very, very common cancer. The good news, I like to say this is good news, is that while breast cancer is very common and more women than ever before are actually getting diagnosed with breast cancer, less women are actually dying from the disease. And that's because they're getting their breast cancer screenings, they're finding it early when treatment can be more manageable. So what is breast cancer? Well, it's cancer that starts in the cells of the breast and within the breast tissue. And then breast cancer if it's not detected early, it can spread to other parts of the body as well. And some risk factors. So people who are assigned female at birth are at an increased risk for breast cancer. Breast cancer does occur in people who are assigned male at birth, but it's less than 1%. So it's just not a big risk. Of course, it can still happen, and it's important to check and be aware of your chest, but it's just not as common. So also getting older, most breast cancers are diagnosed within people at ages 50 and older. And also having a first degree relative, so that's a mother, a sister, a father, or a daughter that got breast cancer. And especially if they were diagnosed at an earlier age for breast cancer before the age of 50, that does put you at an increased risk. And then also if you've had the genetic testing done, if you have the BRCA1 or BRCA2 genetic mutation, then you're also at an increased risk. But that, again, though, just because most breast cancers do occur in people who are ages 50 and older doesn't mean that they don't occur, obviously, in folks younger than 50. Continued breast cancer risk factors are never giving birth, never breastfeeding, or if you have given birth, having your first child after the age of 30. Because certain hormonal factors do increase your risk for breast cancer. And it's important to note here, fewer LGBTQ plus individuals do give birth and breastfeed. And so this is a risk for that population. Also having your first menstrual period younger than age 12 or starting menopause later after age 55 and older. And then if you have long-term use of hormone therapies, that can also increase your risk for breast cancer. And then dense breast tissue. If you have dense breast tissue, like after a mammogram, a provider might let you know, hey, you have dense breast. That does increase your risk for breast cancer. And dense breast just means that you have less fatty tissue and more of like the more like fibrous connective tissue within the breast. And what it does on the mammogram, it just makes it really much more difficult for a doctor to see if there's any tumors present. That's just having dense breast doesn't mean that you're more likely to get cancer. It means that it's harder to find. And that's what increases your risk. And so people with dense breast should really talk to their healthcare provider about any other risk factors that they might have, and then decide on the screening test that they need. Continued risk factors. Well, this just kind of summarizes them. So if you have one or more risk factors and you can have one or more risk factor and not get breast cancer, or you can have no risk factors and get breast cancer. And that's why that's really why screenings are so important for anyone who's assigned female at birth, regardless of their risk factor. So, and I just want to show you, a mammogram is the best way to check for breast cancer. There's clinical breast exams. A clinical breast exam is where the doctor will use his hands to like feel around for any lumps or any changes in the breast or under the armpit. But whether a woman has a clinical breast exam or not is not as important as getting these regular mammograms. So this is just, a mammogram is really just like an x-ray of the breast, except that they take multiple pictures so that the doctor can kind of look through those images and look for any potential tumors. That's the mammogram. And then quickly about them, a mammogram cannot prevent breast cancer, but it can find cancer early before an individual starts to experience any symptoms. And so really mammogram is just the best way to look for breast cancer. And so who should get screened for breast cancer? Well, it's recommended that people who are assigned female at birth, beginning at ages 50 and older, should get a mammogram at least every 2 years. Now, if you are assigned female at birth and you're younger than age 50, you should talk with your doctor about getting mammogram if you're between the ages of 40 and 49. If you have a family history of breast cancer, if you've experienced any changes to the breast or nipples, like swelling, irritation of the skin, any pain within the breast, any lumps, discharge, anything like that, you should speak with your provider about. And so the program I work with, the Cancer Services Program, we will actually cover yearly screenings with a mammogram for uninsured women ages 40 and older, as well as any diagnostic mammograms for women who are under the age of 40, as well as men with findings that can indicate them having breast cancer. So, and then this is just some guidance for individuals if you're a transgender woman or a transgender man. If you have any questions about, well, I don't know what to get. So this is like a nice little kind of guide that you can use. So if you are a transgender woman and you have been taking feminizing hormones for 5 years or longer, it's recommended that you start getting your annual mammograms beginning at age 50. Now, if not, well, if you have a history of breast cancer, then it is recommended to begin getting those screenings as well, or at least speak with your doctor about when to start getting those screenings. And then if you're a transgender man, well, if you have had chest reconstructive surgery, then it's recommended that an annual chest wall and auxiliary exam by a healthcare professional, that's recommended. But if you haven't had chest reconstructive surgery, then you want to continue with those annual mammograms. And of course, if you have a history of breast cancer in the family, it's important to get screened as well for breast cancer. So this is just a nice, useful tool to use if you're a transgender individual. And you can even, I don't know if your doctor has seen this either, you could bring it to the doctor's office, print it off. Okay, so that's breast cancer. Now, cervical cancer. This one doesn't take as long. Cervical cancer, what it is that, well, any individual with a cervix can develop cervical cancer, and it starts with any abnormal changes to the cells within the cervix. And cervical cancer tends to grow quite slowly over time. And most cases of cervical cancer are actually caused by HPV, the human papilloma virus. And HPV is a super, super common virus that's passed from one person to another during sex. And it's estimated that over 50% of the United States population has been exposed to HPV, except most people will fight off the infection without even realizing that they've been infected. It's if that infection persists within the body, then it can lead to cervical cancer, as well as some cancers of the head, neck, and genitals. So it's not just cervical cancer that HPV impacts. So as I mentioned before, nearly all cervical cancer is caused by HPV, but there's other risk factors as well. Age. So most cervical cancers are diagnosed in individuals who are 30 years of age and older. And also screening. So people who have not been screened or haven't been screened in a long time could have cervical cancer and not even know it. And so if you do have a Pap exam, a Pap test, then and it comes back as abnormal and you don't follow up with your healthcare provider, then that also puts you at an increased risk for cervical cancer. And then, of course, smoking. And we know that LGBTQ plus individuals have higher rates of smoking, and they also have higher rates of HPV infection and related cervical and anal cancers because of that. So it's really important to if you have a cervix, it's important to get screened. So some additional risk factors, if you've been treated before for cervical cancer or for any abnormal cells within the cervix that could become cancer, then you're at an increased risk. If you have used birth control pills for 5 years or longer, that puts you at an increased risk. If you've given birth 3 or more times, or you have multiple sexual partners, if you if you've had HIV or if you have HIV or another condition that makes it hard for your body to fight off health problems. And then also if you had a mom that took diethylstilbetrol while pregnant with you, then you're also at an increased risk for cervical cancer. And so the DES, diethylstilbetrol, was given to women to combat pregnancy complications between 1940 and 1971. So if you weren't born between 1940 and 1971, you don't have to worry about it because they stopped. That's no longer allowed for women to take DES. But if you were born during that time and you're comfortable with talking, well, hopefully you're comfortable with talking about if you have your mom around and you can speak with her about this, just it's a quick question. She might not even remember, but it's good to know. So a screening test for cervical cancer includes the Pap test, also known as the Pap smear, as well as a high-risk HPV test. So those are 2 options. They can be performed at the same time, or you can just do the high-risk HPV test depending on your age and your risk. And what the screening is looking for when they go in and they scrape the little cells off from the cervix is that they're looking for any changes to the cells. And so if they come back, if any cells do come back as abnormal, then your doctor will give you a call, do some follow-up, and so get that taken care of. In the high-risk HPV test, it's very much the same as the Pap, but it's just looking for the types of the virus that can cause cases of cervical cancer. So those are the screening tests. And now these are the recommendations for folks who should get a screening. So anyone with a cervix ages 21 to 29 years old should get a Pap test every 3 years. Now, individuals with a cervix who are ages 30 to 65 should get a Pap test every 3 years, or a Pap test and a high-risk HPV test every 5 years, or just that high-risk HPV test every 5 years. Now, if you are younger than age 21 and you have a cervix, then it's really not recommended to get a cervical cancer screening. And if you're over the age of 65, you should talk with your healthcare provider about your need to keep up with these screenings. You might not need to, or you might have risk factors that can indicate that you should keep up with those screenings. And so what our program will cover is we cover a Pap smear for individuals with a cervix starting at age 40 and older every 3 years. or we do also cover the HPV test every 5 years, like a co-test. You can get the pap smear and the high-risk HPV test. So that's cervical cancer. And then finally, colon cancer. Colon cancer is a really common cancer for folks in the United States. And it's a cancer that's preventable with screenings. So it's really, going to spend a little more time here. So what colon cancer is, it's cancer that starts in the colon or the rectum. About 80 to 90% of colon cancers actually start out as these little things called polyps. And you can kind of see what a little cross section of the colon here. Another name for the colon is the large intestine, or sometimes they'll just hear it as your guts, but that's the colon. And so the polyps, it takes many years for a polyp to potentially develop into cancer. And so, and I'll talk a little bit about like the colon cancer screenings, but by removing those polyps, you can actually help to prevent colon cancer. So what are some of our risk factors for colon cancer? Well, age, again. I mean, it's good to get older. At the same time, maybe not great for all things. So 9 out of 10 individuals, around 9 out of 10 individuals, colon cancer, getting old, 9 out of 10 colon cancers happen in individuals who are ages 50 and older. And also if you have a so obviously it's VIH, that's a big deal. Now also, if you have a personal history or a family history of colon polyps, colon cancer, or another bowel disease, something like irritable bowel disease or Crohn's disease, that increases your risk for colon cancer as well. And then, so those are things we can't control, but lifestyle factors actually play a big role in our risk for colon cancer. So if we are overweight or obese, we are at an increased risk. Consuming alcohol, it doesn't matter if it's wine, liquor, beer, anything. Drinking alcohol does also increase your risk. It's recommended for women not to consume over 1 alcoholic beverage a day, and for men not to consume over 2. And of course, there's no guideline for transgender individuals. But also not exercising enough. It's recommended that we get 150 minutes of moderate physical activity a week. So that could look like 30 minutes a day, 5 days a week. So not getting enough exercise, using tobacco, and this keeps coming up because it's important. Tobacco use does increase your risk for many cancers. And then also, this is unique when it comes to colon cancer, is consuming red meats, red and processed meats. So research has shown that consuming over 18 ounces of red meat a week does increase your risk for colon cancer. And consuming any amount of processed meats, that includes things like deli meats, smoked, any type of like preserved meats, does increase your risk for colon as well as stomach cancer. So I like to say, just try to get more veggies and more plant-based foods in, and just try to limit your consumption of red and processed meats. You don't need to, if it's something you enjoy, you don't need to like cut it out of your diet or anything like that. It's just, be aware of how much of those foods you're consuming. So the screening tests for colon cancer include those take-home fecal tests. There's the FOB test and then the FIT test. It's the fecal occult blood test and then the fecal immunochemical test. And then, so those are those take-home tests. You can do those in your bathroom. There's also the sigmoidoscopy, which is a lot like a colonoscopy, where they send up this little flexible, I'm not a colorectal surgeon, but they send up like this little, a long, thin, flexible lit tube that can check for polyps within your colon and rectum. And the sigmoidoscopy just checks for those polyps in the lowest part of your large intestine. And the whole colonoscopy obviously checks the whole colon for those polyps. And during a colonoscopy or sigmoidoscopy, the doctor can find and remove most polyps in some cancers. And this test, typically the sigmoidoscopy is done every 5 years and colonoscopy is done every 10 years for average risk individuals. Now, it might be recommended that you get it every 5 years or every 7 years, depending on your health history. So those are the tests. And then this slide just shows you some of those take-home tests. So on the top right, we have that Cologuard. I think most people have seen commercials for Cologuard. Like there's like the woman swimming and the little Cologuard guy is walking by next to her. So that is, that's not a kit that we provide. We pay for, we send individuals who are with the Cancer Services Program who don't have health insurance. We send them this little brush kit, which is the bottom right. Not so bad. It's the one on the lower right side, and it says ensure. And what that is doing is you just take a little sample when you go to the bathroom, you like swish it around in the water and you just kind of paint it on this little sample card. And what it looks for is it looks for any hidden blood within the stool. And so if that test comes back testing positive for blood within the stool, then it's going to be recommended that you go and you get that colonoscopy, because blood within the stool can indicate that you might have a bleeding polyp. So it could, and it does, if you have blood in the stool, that doesn't mean that you have colon cancer, but mean that you could. And that's why we would want you to then go get that colonoscopy. And then, so who should get screened for colon cancer? All individuals ages 50 to 75 should get screened. And actually this recommendation did just lower this year. So actually beginning now at age 45, it's recommended to get your colon cancer screening, because research has shown us that younger people are getting diagnosed with colon cancer more often than before. So that is why that age did lower, starting at age 45. I got to update this. Also, if you're at an increased risk for colon cancer, then you might have to start getting screened early. For example, if you have a parent, let's say you have a parent that was diagnosed with colon cancer at age 50. They got their colonoscopy, they came back, they said, hey, I have colon cancer. And that's age 50. So you would actually, that puts you at an increased risk. You would then want to start getting screened 10 years prior to their diagnosis. So if you have a parent that got diagnosed at age 50 or a sibling, then you would want to start getting screened at age 40. And if they got diagnosed at age 40, you would want to start getting screened at age 30. So if you are in increased risk, you might want to start getting your screenings sooner than age 45. And so again, colon cancer can be prevented with regular screenings. It's so cool that we have a way to actually prevent a type of cancer, a very common type of cancer, and a very common cause of cancer death. The leading cause of cancer death is lung cancer, but colon cancer is the runner-up. So it's dangerous. So other ways to lower your risk is to, drink less alcohol, exercise regularly. That can be going for a nice walk, staying at a healthy weight, getting to and staying at a healthy weight. It's easy to say, harder to do. Eating healthfully, and then not smoking, or if you do smoke, quit. There's a ton of resources available for quitting, and I can always help people get connected with those resources as well. And so we do know, though, that within the LGBTQ plus population, folks tend to drink more alcohol, tend to smoke more, and tend to be overweight. So that's really important for this population in particular to get these healthcare screenings. And this is just a kind of summary of what we do. We do pay for the breast, colon, and cervical cancer screenings and follow-up services at no cost for individuals who qualify. And we pay for these services. We have almost 200 providers that are credentialed with us. So even let's say you live like in southern Seneca County, or you live in Wayne County or something, there's providers nearby that can help you with screenings, right? You don't need to go to Rochester to get your healthcare screenings. Unless you want to, we can do that. And so think about screenings even now, you know, medical office, I'm here in Thompson, we're following COVID-19 safety guidelines. So really talk with your healthcare provider about your screenings, and our program, again, can help you get screened even if you don't have health insurance. And this is just my contact information. This is my colleague, Gina, her contact information and my contact information. You can give us a call, you can email me, you can go to our website and find out more information. So we're everywhere. So that's it. Here, I'm going to stop my share here. If I just exit, does that work? Yes. Yeah, sorry, there's a lot of information.
Yeah, so thank you so much for talking about all of that and being vulnerable with us. I know cancer has touched a lot of people in a lot of ways. So this is really important information, and I certainly learned things I had never heard before. I think we had a couple of follow-up questions, if you don't mind us snagging you.
Yeah, so this one definitely strikes close to home for me because I personally have had experience trying to access healthcare and doing the dance with insurance, not wanting to cover it or whatnot. And we just recently we're having a conversation about the lack of inclusion of a lot of LGBT statistic gathering in any data collection. That's not just limited to the healthcare field, by all means. But so if an individual is looking to get cancer screening done, but is not currently aware of a provider where they feel comfortable doing that, is that a referral that your department's able to help kind of provide?
That is something, so I will say a lot of individuals, LGBTQ plus individuals, find out what providers they're comfortable with through kind of word of mouth with within that community. That's something that I know we can talk with you about, but it's not something that we don't have like a list that we can refer to. But I'll look into. I like that idea. I'm gonna speak with Jana about that because it would be nice to actually put together a list. I know in Rochester there are some providers like Trillium Health, which is very proactive and very inclusive. I've heard really great things about how comfortable folks feel there. But I would be happy to put together a list. I mean, it's kind of, right, there's not data collection, right? We're not going around asking providers, how do you feel about having a transgender woman, and come for a cervical cancer screen, or a transgender man come for a cervical cancer screening, or a transgender woman come for a prostate exam. That's not something that we're currently asking providers. But I'll look into putting a list together.
Yeah, definitely. That's something too. Planned Parenthood is exceptional in providing inclusive medical care services as well. And they have an office here in Canandaigua. I know that I've heard really amazing things about the team there.
Yes. Yeah, and we do work with Planned Parenthood as well, because they can do some of those cancer screenings.
Awesome. The other thing that I wanted to ask you about, and I'm speaking again from personal experience, I know a lot of trans men purposely don't go for mammograms or try to access any care related to that because everything is pink, right? And it's been very kind of framed as a women's issue. And that's not just true for trans men, that's true for all men, is that they don't often consider being screened for breast cancer. So what are some ways that we can kind of help break down like that gender stigma that's kind of attached to that screening?
That's a hard one, right? Because we have that big call it parade. We have that big walk every October, right? In Rochester, where everything is pink. Everyone dresses up in pink. And I remember going to those walks and just being like, this is a lot of pain. That's a hard one because it's so ingrained within outreach. It's, I have a pink tablecloth for when we have breast cancer screening events. And I think that would come more educating providers, I think, would help about how to not apply gender to certain healthcare, because that can be really off-putting. And we really want people who are assigned female at birth, people who need their breast cancer screenings, to go and get them and not feel like there's a stigma associated with that breast cancer screening, that they have to identify as being a woman. So I think that I read a tip. This is from a tip that I read from a provider level, to like, you can wear like a rainbow pin or have on our badges like the ally, the pronouns. Those little things can help. But as far as all of the advertising, everything being pink, that's something that I don't know what to do about that, kind of like, other than not use my pink tablecloth so often.
I know we talk a lot about breaking down like the gender attachment to certain colors. So I think there's responsibility from all of us to kind of break down that link that we all have. So by no means is the onus completely on you or on medical care providers. I think that's something we can really work towards together.
Yeah. And one thing that could help would be for a medical, it'd be really great if people felt comfortable, like medical institutions would feel comfortable maybe having a rainbow flag outside their institution to show that this is a comfortable place. Things like that. But I don't see why not. But for someone that says, I don't see why not, there's always going to be someone that says, well, I see why not.
Right.
So it's ongoing. I think we've come really far the last 20 years or so with trying to have things be more inclusive, but there's still a long way to come. I mean, I have a pink paperclip that was part of Youth for Breast Cancer. They were given to me.
Yeah.
Because
it is deeply ingrained, and it's when we talk about, even when we're talking about using pronouns, we always bring up the fact that society is a really good tool for training people, and it's really hard to unlearn certain behaviors or certain stigmas. But I think you're right. I think there's been so much progress that has been made. That's not to say that the fight is over, but there's so much progress that has been made, and so many more voices that are sort of taking up that mantle for the people who can't necessarily use their voices, including people like you who are coming here and bringing this education to people and explaining why it's so important. Because people are like, well, I don't want to go to the doctor, I'm fine, I haven't had any issues yet, right? But like, we don't know that, we just haven't had external issues, so we can't be saying that, but a lot of people do say that. So hearing places in our communities that say that they're committed to helping the LGBTQ community and then actually showing up is huge, and I think it sends a message that can never be understated.
So I just have a couple of quick plugs that I want to make sure that I pop into this video, because these things are pretty relevant. We are a member here of a national organization called Centerlink that connects LGBT resource centers across the country. They have a subdivision called HealthLink that specifically works on providing resources and assistance to healthcare providers to help increase knowledge and create more inclusive healthcare provision options across the country. And then the other thing, and anyone who has interacted with me at all in the past 2 weeks has already heard about this, but right now, New York State is actually doing their survey of LGBTQ folks' comfortability accessing health and human services. I think they're calling it the New York State Health and Human Services Survey. And so any LGBTQ identifying individual over the age of 13 can fill out the survey. It took me about 20 minutes. It is fully anonymous, but the data from that is going to be used to really kind of help inform the priorities of where more training and more resources need to be invested in our state for care specific to this community. And so that survey can be found at nyslgbtq.org. And that's brought by the network of LGBTQ services across New York State. So hopefully with that, they're being very, very good with that about collecting more of that detailed information that we talked about, how we don't ask, we don't look for that. So I think that's going to be a bit of a game changer when we have to go off of.
That's exciting. Maybe it'll yield some standardization for questions too.
Yeah, that'd be fantastic. So I know that we're continuing to move that needle, and that's all we can really keep pushing for. So Hannah, thank you so much for spending the last hour talking to us about the cancer screening and understanding what that looks like and all of the ways that our community can access this, because I had no idea that cancer screenings were provided at little to no cost for people with no insurance over a certain age. And I think that's going to be a real game changer for a lot of the people we serve. So thank you so much for talking with us. Thanks for coming on Queerantine and being vulnerable with us. And hopefully we're going to get together to work together again soon.
Yeah, thank you. It's fun.
I'm so glad to hear that. So we will be back in another couple of weeks with another video. Until then, hang tight and keep yourselves safe. Bye, everyone.